All right, let's get started. Our first speaker is Mary Lombardino. Sounds like it's echoing a little bit again. Mary's a speech-language pathologist with more than 25 years of experience in adult neurorehabilitation, specializing in cognitive disorders and brain injury. She's dedicated her career to helping patients and families navigate the real-world impact of cognitive changes, translating clinical testing into meaningful functional strategies, and meeting the patients where they are. Mary's going to spend some time now helping us understand that cognition is not just a score. It's something to be lived, it's something to be experienced. Thanks, Mary.
And this one's on as well.
Okay. I tend to move. There we go. Can everyone hear me? Wonderful, good. Thank you very much, Dr. Houghton, for that introduction. I am thrilled to be with you here today. I'll be perfectly honest, I never expected anything like a beacon conference where both providers, individuals, caregivers, professionals that are involved in the field of Alzheimer's disease, memory disorders, dementias. It has so many different names that we can all be together in the same room discussing different topics, and the focus on those topics be about restorative and what we can do. A little bit about myself. As Dr. Houghton said, I'm a speech-language pathologist, commonly known in the medical rehab world as a speech therapist. I have been practicing since 1998. At that point, I was single and young. Now I'm probably should go to the women's health memory disorder issue, as well as been married 26 years, have 4 children, and now I am a grandmother. So that's the amount of time and the amount of life experiences that I have had while I've worked in this field, working with individuals, working with their care partners is what I like to call them, because not everybody has a family member. Sometimes it's friends. We're good? Okay. I think he's hooking up my remote control.
Yes, ma'am.
Okay. So at the beginning, I'm a new grad. I'm in an inpatient, outpatient rehab unit. And half of the people on my caseload, half of the referrals I'm getting, therefore, knee replacement surgeries, therefore hip replacement surgeries, and that's their primary diagnosis. I'm going, well, wait a minute, where's my strokes, okay? Where's my aphasia? Where's what I'm used to seeing? Even though these people have the same language impairments as someone that may have had a traumatic brain injury, a head injury, a stroke, hypoxic brain injury. They have language problems, they have memory problems, they have issues with attention and problem solving and all of it. And so the older therapists that I'm working with, they say, just treat the symptoms. It doesn't really matter what the diagnosis is, just treat the symptoms. Maybe it's anesthesia. Anesthesia did it. And it's like, well, okay, but we also have half the population in here that had the same surgeries, they had the same anesthesia, and they're not exhibiting the same problems. So I started doing a lot of research on my own. I consulted with professors. I consulted with a neurologist that I knew in Baton Rouge. And at the point in time, and I have these crazy diagnoses on the charts of deconditioning, which we don't even use anymore in healthcare, which is a generalized decline of physical and cognitive function. And the neurologist that I worked with at the time, who later becomes my husband through all this, it worked out well. He said, it's Alzheimer's disease. It's all Alzheimer's disease. It's not diagnosed. At that point in time, it was extremely true. Let's fast forward a little bit, because I think I only have 25 minutes. We're going to fast forward a little bit. I left the hospital setting of rehab medicine about 3 or 4 years ago. Even at that time, we're still not getting the diagnoses that we need to accurately treat, compensate, modify, and accommodate this disease, whether it's Alzheimer's disease, Lewy body disease, frontotemporal dementia, or other diseases that you'll get some names of possibly today in some of these other speakers. So what I did is I developed an outpatient speech therapy program that focuses on the evaluation, that focuses on an individual's strengths. For individuals that have memory problems, they know they have memory problems. We know that there's a problem with memory. That's why they're there. That's why they're seeing us. So what's the strengths? What can they do so that we can target their weaknesses, which in the majority of cases is the memory, as well as do they have problems with attention? Do they have problems with processing speed? Do they have problems with understanding complex language that they hear? Do they have difficulties finding the words that they need to express themselves? And so by finding their strengths, we can target those weaknesses. So the cognitive evaluation that I do, the goal for you today when you walk away from here, whether you're a provider, a healthcare provider, whether you're an individual who actually is living this, or if you're a care partner that's supporting someone, is to realize that the cognitive evaluation, first and foremost, is nothing to be afraid of. It's something that will be the first thing you do on your initial visit with any healthcare provider. Fundamentally, we have to get a baseline of function. It should be something that is not excessively time-consuming. It can be short. It can be very painless. And also, it is something that hopefully you can see the function and the purpose of the evaluation and how it's going to guide your therapy going forward. Okay, here we go. Okay, we're there. The concept is there's multiple tests. You're going to hear the term. We're going to get some testing done. You're going to have an assessment. You're going to have an evaluation. We need to get measurements. Nobody likes to take tests. I hate taking tests, especially you're going to walk into a room, you're with a new healthcare provider, whether it's your physician, whether it's a mid-level provider, a physician assistant, whether it's a speech pathologist, and they're going to start talking about testing. Again, it's something that I would hope whoever you're working with, they're building rapport, you feel comfortable, and at the end of the day, this is no big deal. Okay, this is not going to define who you are. It is simply a window. It is simply a crack so that your provider, your therapist, your physician can get some insight into some of the difficulties that you're having. The components of the cognitive evaluation, there's 3 basic components. I'm not going to spend a lot of time on this because I really want to be able to talk about what I do. And I think that's why Dr. Rennie asked me to speak. Any therapist can come up and give you the ins and outs of what a cognitive evaluation is. There's a standardized assessment. These are the norm-based, scientific, research-generated measurements that look at the quantity. They're not looking at quality. They're very strict as far as the instructions for the testing, the timing for the testing. There's questionnaires. Questionnaires are basically qualitative measures, the complete opposite of the standardized, where it's quantitative and all about the numbers. And then there's also the non-standardized assessment, which is what I do. I base my assessment, I use the framework of a standardized assessment, so I have that score that is needed for documentation, baseline function, but I use that as a framework for my non-standardized assessment. I'll talk a little bit more about each one, and I'll give you the names of some of the ones that I use and I find are most useful. The Cognitive Linguistic Quick Test. It's also commonly called the CLQT. It's by Nancy Helm Estabrooks. who is a speech-language pathologist. She's a PhD. I had the wonderful opportunity back in, I'm going to say approximately 2002, when she designed this test. She presented it at the American Speech Language and Hearing Association conference here in New Orleans. And I got to work with her, I think it was a 2 to 4 hour session. One of the things that is wonderful about this test is that there's a screening in it of a clock. And anybody knows, whoever goes to get cognitive testing, you're always going to see a clock. Somebody's going to break out the clock. Her screening of the clock is actually a 13-point scored separate assessment. She spent an hour using hundreds and hundreds and hundreds of normed-based examples of how the pattern in clocks can help guide whether this person might have a traditional Alzheimer's disease versus a Lewy body disease. She measures everything from the size of the print, whether the numbers are rotated, whether they're in a circular, whether the hands of the clock are symmetrical. So I really, really like her testing. And for me, that's the standardized assessment that I base my framework off of. It looks at 5 different cognitive domains. It looks at attention, memory, problem solving, executive function, and language. Of all of these tests, my one that I find is the most comprehensive is the Arizona Battery of Cognitive Communication Disorders. This test is extremely detailed. Unfortunately, it takes a really long time to do. So in my therapeutic setting, I can get all of my testing done in about an hour, which is comfortable. It's comfortable for my clients. It's comfortable for their care partners as well as for myself. So I like that one for some reasons, but I don't use it that much. You will probably most often see the MoCA, the Montreal Cognitive Assessment. This test, I'm doing some research for this presentation, the Montreal Cognitive Assessment has been validated in over 7,000 scientific journals and articles. It is the most widely used, the most norm-based of any other cognitive assessment that I came across when doing my research. What's great about this, for any providers that are out there, there are multiple versions. You do not have to do the same 8.1 version of the MoCA, especially if you're assessing someone within 3 months, because there is a test-retest validity issue. Your clients are learning the test, not to mention their family members might be in the waiting room saying, oh, don't forget, she's gonna ask you, And they ask you every time, don't forget the 5 words. So I get it. I've been there with my own dad and have done it. Don't forget today's date, the date, right? Because it's coming. So there are multiple versions. There's also a version of the MoCA if you're visually impaired. There's also a version of the MoCA for anyone that has a low education level. For any providers that might be online or here in person, there's also an audio-visual version of the MoCA that if you're doing a telemedicine visit, you can do the MoCA for that as well. So I really like the MoCA, and I do try to include it at some point during my therapy because more than likely you can kind of pull that a year, 2, 5 years later, and you've got a baseline. But I would always do another version of that MoCA, so you're not doing that same 8.1 version. Another thing I would say about the MoCA for any providers that are out there, actually my daughter asked me to say this, she's a medical student. There are instructions for the MoCA. So for my individuals and care partners, that's not necessarily important, but I have seen many a young therapist grab the MoCA and they're just giving it. I highly recommend that you take any providers or your staff, you have them take the 1-hour credentialing course to actually be able to administer the MoCA. That's going to increase the validity and reliability of the test that you're giving your clients. It's $95, and there was actually a study done that healthcare professionals that took the credentialing course increased their reliability of their scores from 33% to 79%. So it's really important for any healthcare providers or your staff that they get credentialed. Another one that I do like a lot is the St. Louis University Mental Status Examination. It's similar to the MOCA in that it's the same 30 points. It doesn't have the different versions, or not that I'm aware of. The Stroop Color and Word Test, I like it. It's good for assessing attention. I actually use it a lot in therapy, or have with a distractor. It's already a test where there's a built-in distractor, but I like to add some as well. Minicog, you only have 5 minutes as a provider to get a cognitive assessment in. You need 2 for CMS because you're trying to get some therapies approved. Minicog, you can do it in less than 5 minutes. For individuals out there who have concerns about memory, the self-administered gerocognitive examination, or the SAGE, is actually a test that you can give yourself. So like Dr. Rennie had said at the beginning of this talk, is we want you to advocate for yourselves. There's not enough providers out there, much less providers that are up to date, interested, and are at the forefront of Alzheimer's disease related diseases that cause cognitive changes, neurocognitive changes. So I do recommend the SAGE for my clients. At the very bottom of my list is the mini mental state examination. This has the lowest sensitivity that I have ever seen. What does that mean? It means that it is extremely basic. So a mild on the MMSE may not actually be a mild compared to some of these other tests. Depending, if I was a therapist in an acute care unit, I might use a mini mental state exam. You know, they just came out of surgery. I got a consult because of some new onset cognitive changes. Somebody might want to flag me if I'm going really over. I don't know if anybody's monitoring my time. Okay, questionnaires. I'm going to skim over this because I want to get to the other component. Questionnaires, these are the qualitative measures. You can go back and pull any of these. Some of the questionnaires are really designed for the care partners. Some of the qualitative measures here, or the surveys, I modify them. I tell my clients to modify them. One of these likes to compare current activities of daily living or instrumental activities of daily living, which are things like utilizing technology, driving, cooking, managing their finances, paying bills, those more complex functional tasks, not just, you know, dressing and eating. That's way more basic for activities of daily living. It compares it now to 10 years ago. Well, maybe 10 years ago isn't appropriate. You don't have to throw the whole survey away. Change it to 1 year, change it to 2 years. And it is good to keep a record of those. You should have a file of your questionnaires, your surveys, of any self-assessments that you're doing so that you can look at those over time. As we all know, these diseases can change so minutely, so slowly over time, that as you're living it day and day and day, it's hard to measure what that change is, if there's been any change. Okay, 9 standardized assessments. This is what I do in my clinic. This is where I find the most benefit is to assess functional change and to address functional needs for the future. I'm looking at individual tasks within a specific cognitive domain. I combine screening tools, I combine subtests, I've made up my own. So, you know, for attention, for instance, there's a very popular trails A and B, right? You have to connect all of the numbers, then you connect all of the numbers and letters, and how fast can you do that? For most people, it's a fairly basic task, and they don't have problems with it in very mild stages or even moderate stages. So I developed one where there's 3 steps. We alternate between numbers, letters, and Roman numerals. So it's a 3-step sequence that increases in value. I have done it so much, I kind of like to have a cutoff time for about 5 minutes. But really what I'm looking for, and another thing about the assessments that I do all of my own assessments. So I'm watching the individual and the family member, which is very important, while they're doing it. Does the processing speed slow down? Are they now having problems? Are their eyes, their visual ocular motor, you can see it on the page, you know, are they having to scan over and over again? So all of those things are really interesting to look at. And so I have made up some of my own subtests, and I encourage anyone to do that. Okay. I like to adapt them to my individual that I'm working with, and I base that off of my interview, and I'll get to that in a minute. They're very flexible. The standardized assessments are not flexible in any way, shape, or form. And they're really focused on more real-world function. I'll give you an example of that when we get to the memory. Okay. The clinic where I work up in Baton Rouge, Louisiana, is called PMIC, Physical Medicine and Injury Center. My cognitive evaluation, I do a combination, as I said, of standardized and individual measures or non-standardized. So my whole assessment, you could say, is a non-standardized assessment using these multiple parameters. Very first thing, through my interview process, I like to identify any barriers that I note. To begin with, I always work with individuals and their care partner. If I do not have a care partner to work with, it really kind of is a red flag, and that's a huge barrier right off the bat. Of course, the individual that I'm working with has to consent to that. Is it okay if your spouse comes back? I have had a couple of times where the individual says, no, I don't want him back there. And that's fine, especially for the testing. And I say that's fine. I will explain to them, though, the care partner gets a lot of information by just kind of sitting back out of eyesight, so they're not a distraction, and watching the individual complete the testing. They get to see the processing speed. They get to see their alternating attention. And most importantly, they get to see the memory. And we'll talk about that a little bit more when I get to that individual part. I like to, as I said before, the whole point of my assessment is that I identify their strengths so that I can target the documented weaknesses that we find in the testing. It's insightful for both the individual and the care partner in the room. They can see it in action, the different cognitive domains and the different problems that the individual might be having. Also, while I'm doing the testing, I'm giving strategies because I want to see, well, how stimulable are they going to be to therapy with me? So if I give them a choice for a memory question that we did an hour ago, are they now able to answer it? And they're able to answer it repetitively throughout the testing. I can give them choices, and now they're 100% accurate. Without the choices, we're now like less than 20% accurate. Such a simple strategy, and the family member or the care partner was able to see that. And then I'll go back and I'll highlight that. Of course, with any type of assessment, we do establish a baseline, and we use it for a plan of care. How are we doing on time? What time is it?
You're great.
I'm good.
Yep,
oh, okay, fabulous. Somebody flagged me because my watch says like it's wrong. Let's just put it that way. Okay. All right, wonderful, good. Okay, so cognitive evaluation. This is what I'm going to be demonstrating and talking a little about more for you today. These are my 7 components that I do. The very first one is the interview. So important. This is where I get my history. This is where I build rapport. This is where we talk about where are you from? What type of work did you do? What's your education? Where'd you go to school? I'm in Baton Rouge, right? So trust me, Baton Rouge, LSU. That's all there is to it. I mean, rapport has been established immediately. My daughter's in Tiger Band. Oh my gosh, we're in Baton Rouge, LSU, and my daughter's in Tiger Band. All right, that's it. We're best friends. We're going to lunch next week. I know they are. She is going to be there. She's about this feet tall. She's teeny tiny, and she plays cymbals. So, okay. Which I also learned, by the way, that if you're on the drum line, they pay you extra because you never stop playing. Yes, if you're a piccolo player, you don't get that extra stipend. All right, so the interview, that's where I get most of my information. And also I'm looking at barriers. I am watching, believe it or not, the person you brought with you to that assessment as much as I am assessing you. I am looking to see if the individual you brought with you, if she is sitting on the edge of her chair or he's up on the table, and before you can answer anything, she's jumping in. She's telling you where you went to school. She's telling me what type of work you did, what type of interest you have. She's telling me about all the problems you have about organizing your closet. And I'm like, okay, so what I start to do now is I start turning chairs a little bit. I always like to work at a round table. I think it kind of makes things a little bit more equal. So I'll turn the chair, the individual I'm working with, more to face me, and I'm going to push her chair or his chair a little bit farther out of view. Not rudely, but I just say we need to reposition some things so that we can be more effective with our testing. And it's a little bit of a nonverbal cue that let me work with the individual. You're here to watch. Okay. Next one is processing speed. From the very beginning, from when I walk into the lobby and I introduce myself, I am looking at processing speed. How fast are the verbal responses? Getting up, standing up, walking to my room. Do I notice that there's a delay in the gait? Processing speed, perhaps. From the interview throughout all of the testing, processing speed is really important because it's so easy to modify, it's so easy to compensate. The more I slow down, the more the individual gets to slow down, okay? If I know that there's a problem with processing speed, I'm not gonna hit them with 3 questions all at once as they're just getting out of bed and haven't even put their feet on the floor yet. I'm gonna start a little bit slower. Attention skills. Attention skills is next because attention is the foundation of all of our cognitive skills. If we are or have a history of ADD, ADHD, if we are easily distracted, if we are in pain, if we are not sleeping, sleep is so important for cognition, it reduces our attention skills. If we're upset, if we're angry, if we're excited, if we're sad, if we're depressed, all of these things take it out of our attention skills. If we are multitasking, right, okay, all takes it out of our cognitive skills. And we really see the burden of that in our memory function. Memory skills, when I assess memory skills, and this is kind of that non-standardized portion that I do, I look at verbal memory skills, which is auditory and reading, as well as visual. When I look at these skills, I look at immediate recall, also called working memory, and then I look at it delayed, short-term memory at the end of the testing, which for me is approximately 45 minutes to an hour, depending on processing speed. So with that, I can identify, wow, memory, visual memory is 90% immediate with no delay and 85% at 1 hour. But when I look at reading recall, functional text, okay, not something Jack and Jill went up the hill, that's not functional for us. I like to use a travel magazine, and I've got this 2 paragraphs about this great guy who hurls himself off a waterfall. I like my story. Anyhow, I look at that also immediately and delayed. Let's say that reading recall was only 20% at 1 hour, but the visual recall is 85%. I'll take 85% all day long. And so now I know that in my therapy, I've got a strength to target the weakness, okay? Problem-solving skills, I do verbal, what we hear, what we say, as well as visual. Language skills, I'm looking at their comprehension and I'm looking at their expression. which is their verbal fluency. Basically, guys, it's their vocabulary. Executive function skills, I am looking at their task completion. Everything we do as human beings is task completion. Whether it is getting up in the morning, brushing our teeth, it's a sequence of steps to execute to complete a task. Or if it's when I was putting together my PowerPoint presentation, which I never do these, I've done like maybe 2 or 3, it took me forever. The sequences, the memory, the recall, the problem solving, the visual problem solving, but it's still task completion. Okay. Oh, over here. Oh, there we go. Okay. I feel like I talked about a lot of this already, so I'll kind of skim a little bit. Again, the interview, I talk a lot about who I am so that everyone can feel comfortable. What we will be doing in the next hour together, and also consent. I have to say, through the years, and actually just this past week, I had a gentleman who had a referral to come see me for cognition, and he was irate, angry, came in my room, he's getting rid of his primary care doctor. Why am I in here to see you? My speech is fine. If there's any other speech pathologist in here, you get this all day long. I know you do, and I've gotten it all day long for almost 30 years. Not all day anymore. In the hospital setting, I definitely did. People do not understand that if you're having cognitive problems, if you have problems with memory, attention, problem solving, language, you see a speech therapist, in speech therapy, whether it's inpatient rehab or outpatient rehab. Everybody knows if they have problem walking, they go to a physical therapist, right? There's no question about that. I have problem, pain in my leg going down, have balance problems, I'm going to physical therapy. People even know they have problems with dressing, if they have problems utilizing their hands, fine motor control, that they go to occupational therapy. Very few people, including providers, okay, including your primary care doctors, and even your neurologists, know I'm going to send this individual to outpatient speech therapy for cognition. Now, are all speech therapists created the same? No, we're not. And I have worked with a number of them that said, why do you like working with that population? They're not going to get any better. There's nothing you can do. It's only going to get worse. Okay. So with that said, it's wrong. Just remember that. It's wrong. There's so many things that can be done. And as Dr. Rennie said at the beginning, you're going to be your own advocates for that change. All right. We're going to move on to processing speed. Always look at hearing and vision. Even though the individual, they have hearing aids, you know, my dad, my husband, whoever has hearing, are they working? Because more than likely, they may not be working. So always testing the hearing aids, making sure they're working, looking for those problems. It's going to reduce the processing speed. Quick things to improve on that processing speed. I'm not going to talk too much about therapy. Reducing the environmental stimulation in the environment, right? Background noise. I grew up in a household, for whatever reason, my mom would wake up, she'd turn on the television and the radio. It stays on all the time, it never goes off. Okay, reducing your rate of speech, using visual cues in the environment, which can be written or visual. If the written doesn't work, usually writing works. Writing and reading are two skills that are preserved long-term in most of these diseases. And simplifying the auditory information. Okay, attention. There's sustained attention that I measure, maintaining a task over time. Divided attention, right? Attention is not in a vacuum. There's many different types. Divided attention is maintaining a task while there's an auditory distractor in place. And for distractors, they're not just auditory, they're visual. Did someone walk across the field? Is the television on, even though it's muted, but you can still see all the chase scene in the car going on? Alternating attention, doing two different things. as far for your shifting between tasks. It can be 2 or 3. It can be static, meaning there's no increase in value or increase in complexity. I look at all of that in the testing I do. Identify what the barriers are. You just did the interview. Is there a history of ADD? Are they on medication? Should they be on medication? Is that something that they can look into, discuss with their healthcare providers? Memory skills. For memory skills, we talked about how I do the verbal and the visual, both the immediate and the delayed. Very, very important. Everybody's different. I cannot say that everybody's visual recall is better than their verbal. One thing that I can say, though, is that once we identify what their strength is, it's a great target in therapy for compensatory strategies. I also look at orientation and long-term memory. Perfectly honest, in my testing that I do, I get a lot of the long-term memory component just in the history in the interview, where they went to school, what year they graduated, what type of work they did. All right, problem-solving skills. I look at verbal problem-solving skills, language-based problems, as well as visual. I identify where the breakdown is. Was the breakdown because in the sequencing, there's too many steps? Was the breakdown in the organization? It wasn't categorized. Stuff was all over the place. But when I organized it and I put it into groups, well, now we're successful. And how organization really plays an important factor and is a strategy that can be used in therapy and should be a foundation also for that attention component as well. These things are all interrelated. I hope you can see that point. Time management. Did they not have enough time to do it? They felt rushed, which is really important for whenever they're doing any type of task or executive function at home in the real world. Or do they have enough time to complete it? Or they know, oh, wait, I got 15 minutes and then I got to stop this. I got to go get dressed. I got to go across town. Distractors, quiet environment versus an environment where they have distractors present. Whether it's even, it could be sensory as far as smell is also a distractor. And then was there a memory component? And because memory is their greatest weakness, then that's where the breakdown was for problem solving. Okay, language skills. I am a speech therapist. I should talk a little bit about language. And I do look at receptive language or comprehension, both verbal, so the information they hear, as well as reading comprehension. One thing for the vast majorities of individuals that I work with within this population, their reading skills really remain preserved for a very long time, and it's a wonderful modality that you can use in therapy to target some weaknesses. Semantics and vocabulary. I do different fluency tests. I do a semantic fluency where you're going to name for me as many animals as you can think of in 1 minute, and I'm going to compare it to your phonemic fluency where you're going to name for me as many words that start with a certain letter. I actually have that, I think, in this packet. You can take it with you, and you can practice that at home. You should get at least 12. If you tell me I was a nuclear engineer and I have my PhD, okay, you must give me at least 15, okay? All right, written expression. Writing is also a skill that is usually preserved. And in the cognitive home program that I give all my people, reading and writing is a very important component because we want to maintain those skills throughout time. Pragmatics or social use of languages is usually really great, right? You go to primary care once a year and they say, how are you doing? I'm doing great. Wow, you look wonderful. Yeah, it's great. Tigers are doing good. They've won all those games. And then they're off for a whole nother year. Okay. One of the things that I do like to try to consider is differentiating between an underlying language involvement that might be a result of the biology and the process going on in the brain that's causing the problems versus memory. So right now I have a wonderful client I'm working with. Her MOCA is a 3, but her language skills are so severely reduced that it would be really difficult for her to MOCA to be higher than that. So it's really hard to differentiate between her language problem and her memory problem. We know that there's a memory problem. It's just that the language is so far worse that she essentially has no vocabulary left. And so it becomes extremely difficult for her and to assess her. And then through the testing, identifying strategies that can be used, closed-ended questions versus open-ended questions. Questions that start with a WH. What was it, Henry? Where was it? When was that? Who was that you saw at lunch? Oh, those are really hard questions. If we can give choices, if we can say, when you went to lunch last week with Carol, did you run into Sam or John? Oh, yeah, I ran into John. No problem. So the individual is successful, and that's one of the most important things. These individuals, as you know, they get things wrong a lot. They feel like they're failing over and over and over again. And so through the cognitive assessment, identifying what their strengths are, what they can do, how they can be successful, we're going to target those weaknesses they have, and always be aware of whatever barriers might be present, such as attention problems. This is the phonemic fluency task. I'm going to skip this because I think I'm short on time, people. But you can see I gave the letter L, and in 60 seconds, name for me as many words as you can think of that start with the letter L. No proper nouns, so no L words that start with a capital letter. You can do this at home. It's a great language exercise. Okay, executive function. So executive function skills assess basically completing task. I love my clock from Nancy Helm Estabrooks. Design generation is also part of her test. So I use those a lot to assess executive function. And I'm really looking for here, where's the breakdown? Was it in the time allotment? 3 minutes wasn't enough time. If they would have had more time, they would have been successful. It was the sequencing that got them. It was the organization. It was the memory. They forgot the instructions, even though the instructions are written on the page. And if I go back and I say, oh, your instructions are right here, you don't have to remember them, you just have to, they go, oh, thank you so much. Now they reread the directions, and now they're 100% accurate, and they did it all correct because the directions were on the page. So obviously, having that written information for them was a huge benefit and something that can be used in therapy. But really, the therapy is not important. It's for you to be able to take it home and utilize it on a daily basis to increase success. Okay, so that's how we measure change, or at least how I measure change. But now we want to know what's causing it. What's the biology behind it? Why do these symptoms fail? What's happening in the brain that causes attention to become reduced and fluctuate, memory to become reduced, and behaviors to shift? All right, thank you all very much.